Hello, everybody, and welcome to another episode of the Smart Human Podcast. Today, I'm talking with Dr. William Goodson, who is a renowned breast surgeon and who has spent over 35 years of his career managing and diagnosing breast diseases. He's also done research in environmental health and how environmental chemicals affect the breast tissue, and risk for cancer. Today, we talk about his research, breast implants, reconstruction, personal care product choices, and so much more. So stay tuned. Hello, everybody, and welcome to another episode of the Smart Human Podcast. Today, I have the pleasure of talking with Dr. William Goodson, who is a renowned breast surgeon and has over 35 years of experience in the diagnosis and care of breast diseases. He has authored dozens of peer-reviewed scientific papers, has led groundbreaking research with the California Pacific Medical Center Research Institute, where he studies the effects of environmental chemicals on women's health, including the health effects of chemical mixtures, as well as the health effects of chemicals used in everyday products. He has won countless awards for his work, acted as a clinical professor in surgery for many medical and residency programs, and he has sat on ethics boards for academic medical institutions. He is an emeritus member of the Society of Surgical Oncology, the American College of Surgeons, the American Society of Breast Surgeons, and the American Society for Clinical Oncology. In addition, he has won the hearts of both patients, study participants, and colleagues, and has been listed in the Best Doctors in America reports since 1991. Dr. Goodson, thank you so much for being here.
My pleasure.
So I got to know of you, actually, even though we worked with some common colleagues over the years, when I had been invited to watch a video from a very reputable and wonderful environmental health program called Collaborative on Health and the Environment, which people have access to, and we'll put the link. And I watched this video where you really got on and talked about some really unbelievable research that really had just been published in 2023. And, you know, I want to get into this topic of environmental health and find out really what led you in your career from a surgeon of 35, maybe 45 years at this point, if you haven't updated it seems that you've been doing this a very long time as a breast surgeon. And what led you to the point where in 2023, I'm watching you do this groundbreaking work on breast tissue analysis with chemicals. How did you get here?
Wow. I don't really remember how I got interested in the environment. I'm from Kansas City. And so one night I'm taking a flight. This is how old this was. This was a U.S. air flight, nonstop, Kansas City to San Francisco. I'm in the dark and on the plane, and I'm sitting next to this guy from the University of Missouri Food Science. And we started chatting. He started telling me about how deer, if a hunter shoots a deer in Missouri, it's going to be a different piece of venison than if a hunter shoots a deer in Minnesota. Because in Missouri, the deer have been stealing farmers' corn, and they basically are corn fed. And in Minnesota, they've been eating pine nuts, and pine nuts are a different kind of bitterness and a different kind of taste. And, we always, back when I was young, and I think kids still joke about it a bit, you are what you eat. And I was very aware of that. And then, what got me into the environmental thing was actually, I was supposed to write an essay for a part of a publication, actually the San Francisco Medical Society, on kids. And I got to thinking about it, and I realized that what we really are not watching out for is on our kids is what's going into them, what's put on them, what they're breathing, and all the other, what they're drinking, what's showering down on them. I sort of got interested in that, and I couldn't figure out a way to make it work. And I worked a lot with a woman by the name of Shanaz Derki. Shanaz has wonderful hands and wonderful insight. And we talked about maybe trying to study human breast cells. And I'm probably going on way too long here.
No, keep going. I love this. Go ahead.
Well, we were talking about, Shanaz has this skill of growing cells from all sorts of things. She's grown a huge number of cancer cell lines, but she also can grow benign cells. And growing benign cells is really very difficult. Most people get a success rate of about 5 to 10%. Shanaz runs about 70%. And she's really quite good at this. And what I've been doing, and this was a pathologist by the name of John Abley, got me started on it back in the late 70s, doing fine needle aspiration. And that's a way of putting a needle in the tissue, any tissue. You can do it on a lymph node, you can do it on the liver, but do it on the breast as a way to get a sample of tissue. So I was aware of that idea. And Shanaz and I were talking about how this would be a great thing. But we said, how in the world can we ever pay for it? Because you got to pay for equipment and supplies and techs and stuff like that. And so I was recruited to be on the advisory board for the California Breast Cancer Research Program. And I was supposed to start in January, I think it was 2006. And I decided to just go to one of their meetings beforehand, one of their open public meetings, and sort of just to get more of a sense of it, because it sounded like a good thing. The person who asked me was a woman named Ellen Mahoney. Anyway, I went to this first meeting and they said, oh yes, and we're going to start an initiative on looking at the environment and breast cancer. Now, this was Mel Kavanaugh-Lynch, MEHL, and it's an acronym for something, but Kavanaugh-Lynch, she's run this program for at least 25 years. And they were going to add this. And I left the meeting, called Shanaz and says, I'm going to turn it down because I couldn't be on the board and still be applying for money. So I wrote to Mel and said, I need to really step down now because then there's no conflict of interest. And we applied for a small grant. And the choice of BPA was actually Shanaz's choice. And BPA has been a very hot topic. She knew more about it than I did. I was just interested in chemicals. And, but Shanaz is a wonderful partner. So I do a lot of the talking. I do a lot of the clinical relationships, but Shanaz is very definitely, it wouldn't work without her. And I always tell her that. And she says, well, yeah, but I wouldn't have anything to work with if it worked for you. So we have a partnership. And that's a very good thing.
Yeah, when you described the dates, 2006, I remember BPA, as you know, with Dr. Fred Vom Saal and his colleagues, really was able in that time period, I think, to really show that bisphenol A or BPA, which is a compound that are found in plastics and a lot of other products, one of the most highly, pervasive chemicals even now, but it was taken out of baby bottles that were plastic because of the ability to affect endocrine disruption and endocrine hormone basically changes. And so what you're saying is around 2006 is when you're sort of getting into that area too, because now the literature is starting to really, pick up in terms of those effects.
Right. And then I met Fred in 2008. I go back to Missouri and I actually just wanted to meet him because I'd read all his papers. And by this time we had published our first paper on BPA and Fred had all the animal data. We had some mechanistic data that showed that you take normal human breast cells and expose them to BPA. They do things that you do not want to have happen. And they express genes or they behave in a way that if you go to the, open gene access databases, then you can see, okay, a cancer that expresses these kinds of genes, what's that going to do? And it actually is a much worse kind of breast cancer if it expresses the genes that are elicited by BPA.
And you're talking about BPA exposures that are consistent with everyday use. You're not talking about loads of it.
No, we're talking about laboratory tests, taking human cells and exposing them to quantities of BPA, which are measured the same things that people measure in blood. And we've also done it 1/10 of that and 10 times that. So you get this, same, and you get low and high, and all of them do the same thing. And so we we did that. And I watched one of Fred's lectures. And at the end of the lecture, I came up and introduced myself. And he said, "Oh, I know who you are." I said, I point to that paper and tell my students they don't want to have this happen to them. So he kind of knew about our paper. I was going to tell him all about what we were excited about. And he said, "I know all about you." But you know Fred. I mean, Fred's a great guy. And
he's magnetic, actually.
He's a force. But that's
he's a
worldly
force.
Forces.
Absolutely. And it's funny, the circle of people that he works with and knows, it's just really remarkable because they're typically forces like yourself. So, so that's a really interesting beginning to sort of how you parlayed into some of this work. And you're still practicing at that time as a breast surgeon, right? So you're
correct.
You're noticing things as much as many clinicians do in your population over decades, right? You're starting to see things. So tell me a little bit about what you started to see in your clinical population in terms of breast cancer, and we'll get into that as well.
I think that what you see is more breast cancer in younger women. Kind of unnerving that I retired from my office about a year and a half ago. I still see people on Zoom calls. That's why it's very comfortable to me. And I discuss with them how to manage their cancer, particularly newly diagnosed women. Recently, I've had 2 young women who were the daughters of previous patients who ended up with breast cancer over the course of the last couple of months. That's very unnerving. Another family friend had breast cancer at age 31. So this is a 28, a 31, and a 40. And those are young women. And I was talking to a friend of mine who's a radiologist, who we were just chatting, and she said, "Bill, I want to ask you something. Are you seeing more breast cancer in young women?" And I said, "Yeah, well, I kind of think so." And she said, "Well, I've been involved with 3 women under 20 in the last 2 years." Now, about mid-1980s, I was curious about whether you really would need to worry about lumps in teenagers. And I went through all of what I could find in the world literature on breast lumps and breast cancer in women under 20, or young women under 20, teenagers, what do you want to call them. And I could find about 20 case reports. There was like somebody would write, "I found this patient. It was horrible. And this is all I can find in the literature." There was almost nothing in English language literature about breast cancer in young women. So I think this has changed, and I think it's changed a lot. And one of the things about it, there's a woman at the University of Kansas by the name, just a second, I can't
Let me see, is it Elizabeth?
Elizabeth Cathcart.
Cathcart, right. Is that this article you sent me that was beautiful?
Yeah, that's the article.
Yeah, we'll put it in the show notes if anyone wants to read it.
Yeah, but the drift of that article is that she did something, you won't say great, you would say very instructive and important, and that she looked at nationally publicly available data. There's this thing called SEER, where the government keeps track of all sorts of cancers in, I think it's now 13 areas of the United States. And she looked at the incidence of invasive breast cancer in women under the age of 40. And it went up about 0.5% a year, every year from 2004 to 2017. Now, one of the issues that comes up when you discuss increasing breast cancer is the naysayers always say, well, there's another explanation for it. Common explanations are hormone replacement therapy, mammography, quote, overdiagnosing cancer. Those are the biggies. And, obesity and alcohol.
Delayed childbearing.
Right.
Yeah.
And what you really find is that approach doesn't really hold up. And particularly mammography, hormone replacement therapy, and things like that. And, the women I'm talking about that I've seen personally, they're lean. They don't drink much alcohol. I mean, occasional glass, but these are not women who are drinking 2 glasses of wine a day. These are young women who are basically living their lives pretty normally and not excessively, and who end up with breast cancer. And two of them had a family history, but one of them had zero family history of any cancer and tested negative for every gene we know to look for. She just got breast cancer at a young age. And that's very troubling. And part of the problem is that everybody looks at the so-called, the SEER data that I was talking about. SEER was a national collection that was started in the early 1970s. And if you look at the incidence of breast cancer in the 1970s, it was about 90 per 100,000 women. It gradually went up to about 140 just before the turn of the century, dropped a little bit, and it stabilized about 135 per 100,000 through 2017. I haven't looked at it for the last couple of years. But what you find is everybody says, well, okay, this, 1973 to 1990, that's just more mammograms. We're finding things that aren't important. And women are taking more hormone replacement therapy. Hormone replacement therapy, actually, Premarin Provera got off the ground in 1950s. And I actually have the little advertisement keychain that was, your sample pills, the 4 different colors for the 4 different doses. And so you can say that. But what that overlooks is that big contributors to that, the SEER database are the Connecticut Tumor Registry and the New York Tumor Registry. Those registries had started in the 1930s. And if you look at those registries, the incidence of breast cancer was about 60 to 70 per 100,000 in the 1930s. And all the time between there was a gap. The war, no data was collected in the war, but in the late 40s up to the 70s, every year there's a gradual increase. Now that's before mammography, definitely before mammography, and any amount people were playing with it, but just,
Right.
It was very crude. It was actually started before hormone replacement therapy because all the Premarin push was in the late, this keychain I mentioned to you is from 1958. So that all the hormone replacement therapy and all this sort of stuff takes off at that point. And it's interesting because, you can say, the hormone replacement therapy, but, the earlier hormone replacement therapy until the late 1980s was all straight hormone, all straight estrogen. It was Premarin.
Right.
And if you look at the Women's Health Initiative studies, nobody talks about it because it's hard to explain. But the women who took Premarin alone, took conjugated estrogens alone, took an estrogen without a progestin, they had a slightly reduced risk of breast cancer. So, that's what they were taking in the 50s and up into the 80s. It was only the 80s they started, doing Prempro and stuff like that. So that increase from 1950 to 1970 is despite women taking more hormone replacement therapy rather than, because the risk would go down. That's what the data shows. And so, I think that what's really, people fight against this, that's just old data. But the problem is if you don't look at old data, you don't know where you've been. If you don't know where you've been, you don't realize how the world has changed. And there is, you want to know what changed? Well, DDT became it was a military secret until 1945. And in 1945, it started being used all over the place. There's this rather horrifying picture in the National Geographic that shows a beach in Long Island with the fogger truck going through spraying DDT with a big sign on the side of the truck that says, DDT, powerful insecticide, harmless to humans. Baloney.
Right.
But I remember that when I was a kid in Kansas City because they had this Dutch elm disease bug in Kansas City, and they would spray. They'd come by in the summertime and spray the trees. And
the kids would play in it, right? They thought it was fun, like a mister.
It has a very funny smell. I know if I smelled it again, I would recognize it. Very distinctive smell, but we would go outside and watch the truck go by. So I don't know that we played in it so much as we just sat there and looked in awe at it and figured, it's going to save the Dutch elms. It didn't. All the elm trees died. But the next thing that happened is that DES was discovered, I think it was first synthesized in 1938, or at least that's the earliest publication. And the way to think about DES is BPA on steroids, or closer to a steroid, however you want to say it. There is this, the guy who invented DES was a guy named Edward Charles Dodds. Now, Edward Charles Dodds is sort of the pictures of him. He's this typically stodgy Englishman, slightly bald, kind of a little bit of a pot belly and glasses. But he and the guy, I think it was Lawson he worked with, Lawson or Larson. I can't remember which one it is. I always get it confused. But they were a team, and he did the laboratory work, and Lawson was the synthetic chemist. And there is this absolutely brilliant picture in one of their papers in which somebody had figured out the structure of estradiol, the most common estrogen. And it has a 6-member rings and a 5-member ring. And they put it next to the structure of BPA because they had shown that BPA would work like an estrogen. And then they said, okay, it's got 2 rings and they're kind of close together. What happens if we move them apart? So this one was a ring and a carbon and a ring, and they made it a ring, 2 carbons and a ring. They just moved it a little bit. And they got the strongest estrogen we've ever known. And it is, to me, that was staggering. Now, the important things about this are that A, a lot of it was out there. B, it was used a lot for what it was not intended for. I mean, Dodds was looking for a way to treat metastatic prostate cancer because they knew that estrogens would, reduce the pain and the spread of prostate cancer. And DES was very good for that. But a guy named Smith in the East Coast someplace, he decided, well, this must help women who have miscarriages. And you had this horrible maybe that's wrong, horrible unnatural experiment of a whole cohort of women who were pregnant, who received DES to prevent miscarriages, and who then had little girls who had gynecologic problems, little boys who had, male genital problems. And so what you have is this really big time natural experiment, where, it kind of proved the principle that if you give something to a woman when she's pregnant, it becomes a gift that keeps on giving. Women would have kids, and then their teenage daughters would get clear cell carcinoma of the vagina. And that's a big deal.
DES is one of our biggest, we've had many in the pharmaceutical industry and in the medical world, thalidomide and some other drugs that have gone really, really wrong. But DES stands for diethylstilbestrol, and that was given to women from in like the 71 to 78 period.
40s to the early 70s. I think it was taken off the market.
Oh, it was 40s to 70s. So again, it was given, your doctor, your OB-GYN would give this to women who were pregnant just, in the hopes that they wouldn't have a miscarriage. And yet we now see successive generations. I have DES patients whose grandmother or mother was given the drug 3 generations prior and are still having health effects. And that's shown in the literature as well. But I actually had a patient that said, I'm a DES daughter is what they're called, or DES son. And it's just one of those components of environmental medicines or chemicals that you're going to tell us about that I think people don't think about, that it's not just what you are exposed to as an individual. It's really what could potentially happen to the genetics of an unborn child, because their ovaries, their fetal early cells of male genitalia will go on to have those gene expressions changed in successive generations. So anyway, just wanted to...
Well, building on what you said, one of the things that people don't realize is that when a baby is growing inside of mom, some of the tissue that will become the ovaries is actually growing there, so that the daughter's ovaries are not, to people who say are completely grown, they're not. Actually, there is evidence in mammals that they do grow more eggs when they're older, but it's kind of a small business. But a lot of the eggs that are in a mom when she's, they grow in a little girl fetus. When she grows up to be a mom, those eggs developed when she was in utero, before she was even born. And male, I'm less versed on, but that's a debate that I follow. But the other thing you got to realize, we talk about BPA, polycarbonate plastic, which was it's in the around 1945, 1950. Two separate teams, a team at Bayer in Germany and a team at one of the big research labs in the United States, figured out you could make a very versatile product out of BPA, polycarbonate plastic. And, it's funny, it kind of gets into one of the things is, when you talk about, BPA, leaches out of plastic. If you have a BPA plastic bottle, the BPA or the BPA lining in a can, it will get into the food. It will get into the water. Mm-hmm. And one of the, there's some of the arguments about against being careful of things like that are, I think, disingenuous. One of them is, I heard somebody who would say, well, you need your BPA. You're going to take away my CDs. Nobody sits there and licks their CDs. I have a bunch of CDs in the corner. I'm a dinosaur. I have CDs. I even have vinyl. But nobody's going to lick it. Nobody's going to lick. Maybe they'll spit on their finger and put it inside their ski goggles. But the idea that you have to get rid of the polycarbonate for some of its useful things it's a specious argument. It's stupid and it's misleading. And, it's like, you can have your BPA for the things where you want the plastics that are hard and pretty durable, and it makes a good use for things. So what? I don't care. I think it's also used in airplane windows or something like that. And so you can have that. But, what we're talking about, specious arguments, one of the things that I believe in very much is particularly using organic food, particularly for things that are high risk, like berries and stuff like that.
And especially during the most critical windows of development, as we just talked about, the in utero environment, that's probably the most important time of exposure. If you really want to argue through this successive generation and changings of the genes and epigenetics, you really want to make sure during pregnancy, as best you can, because this is not to cause, blame. It's about doing better. And that is one of the big developmental windows, teenage years, menopause, all the big hormonal explosions of development.
Couldn't be more right. When I was going to carry that forward, the other thought is that some people say, well, you can't sit there and advocate organic food because that's an equity issue. Only rich people can afford organic food. And I'm sitting there saying, no, you don't get it. Nobody should have all that crap on their food. And it should be that food comes without all that crap on it. Now, I have farming interests. I'm part owner of a farm, and I lose that argument all the time because I'm outvoted. Except I'm kind of sneaking it a little bit. I became the managing partner, or at least sort of the pseudo managing partner, and I've got a little 50-acre plot we're going to start doing different things on. But I mean, I've seen the bags of Roundup, they call it. Sounds really cool. That's glyphosate. I've seen the bags sitting there. I've seen people spraying it. It makes my neck crawl. But I think it's very important to realize that this is not an issue of equity. This is not an issue of food deserts. This is not an issue of making it so only rich people can do better. What this is really saying is, if you want equity, it means that the entire food chain is safe, so that poor people and people without advantages, that they won't get poisoned like everybody else. It's funny. I read a book review this morning on a book called Dust, and I don't remember the author. I could get it in the other room if you want, but it's talking about how humans have put dust everywhere, and it always comes back. And they're talking about this lake in the middle of the former Soviet Union that was downstream of a lot of agriculture, but they've diverted so much water that the lake is drying up, and now you have dry lake bed, and all the residue from the agricultural chemicals is spraying all over. But the weirdest example was that the French did above ground nuclear testing in the 1960s in Algeria. And there was a lot of dust, radioactive dust, that settled out over Africa from those tests. Now, fortunately, nobody's testing bombs above ground anymore, I hope, at least not supposed to. But the review ends with the comment that the winds have shifted a little bit. Now all the dust is blowing at France. So we don't, there is, you asked me how I got involved, and I mentioned writing this essay in 1999. And I started out with the quote from John Donne, "Don't ask who the bell's ringing for. The bell rings for you." And, Hemingway famously wrote for whom the bell tolls, because he wrote about the dangers of all this stuff. And then we had a whole world war to prove Hemingway was right. And Hemingway's not a stellar personality, but he was very prescient.
Yeah, we've gotten ourselves into a lot of pickles. There's no question about it. And I say that with tongue in cheek, but I'll be honest with you. It's if I don't have a little bit of levity, I think I would just curl up in a ball with, anxiety. So part of the work I do is obviously trying to empower people, because we can make definite differences, which brings me to my next question for you is, when you intervene in your lifestyle, you can make a difference. You can make a difference in terms of your urine testing of environmental chemicals in all of our everyday products. You can make a difference in your blood levels, even your breast samples, in terms of fine needle aspiration, which is what you've focused some really amazing work on with your colleagues as well. So, tell us about your research and tell us what you found about these interventions that we can make in our choices that may affect our biochemistry.
There are a lot of people who, research is always a team sport. So there are a variety of people who are involved in this. As I said, Shanaz is wonderful at growing cells. Mm-hmm. And one of the things that we were interested in is that people do stuff in tissue culture. And there are some long-standing tissue cultures. Most of them are derived from cancer cells. Most famously is the Henrietta Lacks, the HeLa cells, and the expropriation of her tissue without permission. There's nothing wrong with what they did if they just asked. It's that failure to ask, it's a big deal. And I imagine the woman would have allowed them to do it. But, nobody asked, and we don't know that. So this is kind of crazy. But the one problem with that is that if you take cells out of the body and grow them in the laboratory, they go through a process that's sort of nebulously called transformation. It's a big black box, but they transform, and then they will grow forever. And when cells transform, they change, and nobody knows whether or not they, what that change means. But they do all the studies on the established cell lines. There's MCF7. There are more papers, I think, on MCF7 than anything else. Michigan Cancer Foundation number 7. And I love where you get these names. But that's not the same thing as studying something in a person. That's studying MCF7 cancer cells in the laboratory. So based on Shanaz's expertise, what I started talking to her about was, look, let's do fine needle aspirations. Can you grow cells from that? She says, well, I've been growing cells from cancers on fine needle aspirations. We probably can do real cells. And so what we did is we started out initially getting cells, and, they were high-risk cells in the sense that if I was operating on one breast, I would get the 13-page consigned consent to operate, not operate, but to do a fine needle aspiration on the other breast. I always explain to the person it's like a reverse flu shot, only the flu shot puts in more than I take out with a fine needle aspiration. I mean, you don't take much out. You don't need much. And then I'd, put them on ice, send them off to Shanaz and grow them. So we had this whole way of doing this that we developed. And as I said, it was very much dependent on her skills and my talking people into it. And so we had that bit of information. Then we had the information from the what's the name of this? The study in Salinas. It has a name, and
not Hermosa?
Hermosa study. Yeah, the Hermosa is the sister study in Salinas, and it was run by a bunch of high school girls where they had, I like the high school girls. They don't have to be PhDs or even BA. A bunch of high school kids did this, and I thought it was fabulous. But
and in the Hermosa study, just to share, because it's such a fabulous study, maybe I'll add that to our page. Basically, they took young girls, decided, or I guess they organized a way to reduce. What they did was they switched out their personal care products that had a lot of horrible chemicals based on EWG's website and database. And for 3 days, they switched out their personal care products to, just as effective, but cleaner products. And they had a remarkable reduction in urinary toxic chemicals as compared to before. And it was measurable, and it was done through a lab, and it was very, I think 194 toxins, toxic chemicals, I think were found in that population of young girls. So am I wrong? I think it was I don't know if the numbers are all exact, but it was just a remarkable intervention where they just switched products for 3 days and they saw a difference in exposure.
All of these things have a short half-life for the most. Some of them have a longer half-life. Most of them have a half-life that runs about 12 hours. Mm-hmm. And for those who are not used in terms of thinking of half-lives, it means that whatever you have now, 12 hours later, it's half. 12 hours later, it's half of that. 12 hours later, it's half of that. And by 3 days, that's 6 12-hour periods, you've gone to a half, to a quarter, to an eighth, to a 16th, to a 32nd, to a 64th. And then you really drop down. And what this study showed was that you could actually make a difference. So that's the second thing. First thing was we knew how to grow the cells. The second thing, these people did this. Third thing is that there's a woman named Philippa Darbra. And Philippa is in the United Kingdom. She's retired now, but she's got herself an emeritus status, so she still plays in the lab occasionally at Reading. I think it's the University of Reading or Reading University. Anyway, I took the train down there to meet her. And what she did is she worked with surgeons. She's a biologist. She worked with surgeons, and she got mastectomy specimens. And she also got specimens from reduction mammoplasty women who just wanted their breasts smaller, but they didn't have cancer. And then she had worked with a biochemist who took chunks of this tissue, analyzed it to see what was in it. And what she showed was two things, very important. First of all, a lot of the things that are in personal care products, phthalates and parabens, were actually in the breast tissue. So what you smear on your skin, under your arm or the skin crease or the face cream or something like that, gets into the blood and goes to the breast tissue. We don't have samples of any place else, but we do know what we have in the breast tissue. She did a remarkable experiment on that because all of these things were present in very low levels. And he's kind of like, I couldn't really make a difference. So what she did is she had, I think there were 7 different chemicals, and she took each chemical in the quantity or in the concentration, the dose, whatever you want to call it, that it was actually measured in tissue, and then went to tissue culture. She actually used these MCF7 cells. Like I said, they're everywhere. You got to spray for them. She used these cells, and if you took each individual chemical in the dose, in the level at which it was in the tissue, you got very little response, maybe a little blip, but nothing happened. If she took all 7 of them and recreated the mixture that was in the tissue, bingo. And I think that's a very important principle, because you need to know what you have, not only as one chemical, but this whole panoply of chemicals that we're exposed to all the time. So that was the third thing. So we knew that the stuff got into the breast, and we knew that that you could make a difference in terms of what the chemicals were, and we knew how to grow cells from benign people. So we hatched a plot, and this was Shanaz and a woman named Polly Marshall, who was a breast cancer survivor. And I'm not telling tales out of school because she talks about this. And we got together, and there was a thing, again, through the California Breast Cancer Research Program that was looking at whether or not, environmental chemicals and projects, and it also had to have a community participation.
Right.
And so Polly was a lawyer, so she definitely was not a doctor. But we put in this grant. Actually, Polly and Shanaz were the PIs, and I was just the guy that was going to organize it. I dealt with the institutional review board and all that sort of stuff. And he came up with this plan to do a fine needle aspiration on women's breasts, and then to have them come back a month later and do the same thing again. And we would provide them with phthalate and paraben-free cosmetics for that 1 month period. So we not only changed them for 3 days, we changed them for a month. And we monitored what happened in terms of the quantities of phthalates and parabens. It goes down quite strikingly. What's interesting is that some of these chemicals are associated with cosmetics in particular. There are actually other studies where I look and say, you can tell who's using cosmetics by their urine levels of these chemicals. And those chemicals just went bingo. They went right down. There are a few other chemicals that are not particularly common in cosmetics, and they didn't really change. So that whole part fits together. It was the change we expected, and it was statistically significant. So what we did is we had these fine needle aspirations before and the fine needle aspirations after. And we looked at the gene expression in the cells. People talk about it's in your DNA. The DNA kind of doesn't change very much, but how your body uses the DNA can change. And what we found was evidence that by taking away the personal care products and replacing them with something else, we were able to show that there are changes in gene expression that take the behavior of the cells away from things that are associated with cancer. There are a lot of negatives in there. It's always a little confusing, but you're taking something away and you're reducing a pro-cancer behavior. And this is very exciting. Unfortunately, it's a small study because we were just getting underway as COVID got started, and when the first lockdown came in California, we had patients scheduled for the next week, and we had this conversation and said, well, you kind of like, you can't really ask women to come to the office for a research project when nobody knows whether or not coming to the office is even safe. So we let that go and stop, which is why it's a very small project. But it's the only project out there. There is no other project like this. And this project shows changes that you would not, or actually shows benefit that you would like to have from reducing the chemical exposure, which is basically the opposite of saying, well, if you put the chemicals back, you're going to get those changes again. It's not what you want. Now, when we first looked at this, it was kind of like, okay, maybe. But the other thing that Shanaz did is that most of the cells, we would get the RNA and send it off for analysis. And then some of them, we had enough cells left over, we could do other things. And Shanaz actually did studies where she looked at the behavior of the cells, and the behavior of the cells changed in what you would want, in a way you would want. So that that's what convinced me, because I was a little skeptical. But that part, when the whole cells changed their behavior too, it's a great study. I'm very proud of it. It definitely needs to be repeated. I could not go to Congress and say, change things on the basis of that study. I could go to Congress and say, for God's sake, get off your butt, spend some money, and actually do it in a large number again. So there are a couple of things about it that we did prove also. And that is that it is acceptable to a woman to put a needle into her breast because you can make it so she doesn't feel the needle. Just like your dentist goes in up here and blocks you up here, and then they can chew up your teeth down here. You can go behind the breast. You don't go sticking needles in the breast. They will tell you they don't like that. But you can start way out on the side where it doesn't bother people very much. Put a little bit in, and then you coax a little bit more in, and the whole space behind the breast. People think of the breast as attached to the chest wall. It's not. It's attached to the skin. And all of you women, guys, it doesn't work quite so well. But next time you get out of the shower, bend over and realize that your breast doesn't change your relationship to your skin, but the skin moves and the whole breast moves up and down with the skin. And so you can get into that place, you can make the breast. And the proof of that is that we had no attrition between the first time and the second time.
Right. So no women dropped out because it was too painful or it was too much of a problem.
No women dropped out.
Yeah. And you had I think it was 40 women. Is that total, which is a nice.
We had 40 women. Unfortunately, we didn't have 40. We did a pilot study. And that's the other thing. We did a pilot study with about 15 women. 15 of those women were in the pilot study, and they were all post-menopause. And that was, that was very interesting data. And that's the other reason that I feel comfortable with this. And that is that we found benefits of changing cosmetics in that group too. And there was some discussion as to whether or not we should go public with that. And I said, no, you don't want to do that because we don't, this is a pilot study and you don't want to stick your neck out. I mean, I had the experience, Fred probably knows this much more than me, but I had the experience when we wrote the paper about BPA and somebody interviewed me and there was a blogger on Forbes magazine who said, Goodson's an idiot and quoted, it's a very interesting study. He quoted a study where they gave people, I think it might have been young people, fruit cocktail. And you could measure the BPA going up in their blood and in their urine. And a couple hours later, it's all gone. BPA doesn't stick in you very long. So he said, it doesn't stick around. Why is he worried about it? But what he didn't know is that the body works on pulses. And anybody who's done fertility treatment, started doing injections herself, knows she'd do it on a schedule because you're adding a pulse. And all of normal physiology with hormones works on a pulse. You don't have your your estrogen level go up, your estrogen level.
Right.
It's the same for the testosterone level, the same for FSH, it's the same for LH, it's all these things. So telling me that it's a pulse and it goes away is like saying, no, you don't get it, because if it's a pulse and goes away, it's a pulse. Now, the place where this is most telling is that there are some studies that were done in the 1980s where they did around-the-clock blood sampling. I don't know how they talked parents into this, but did around-the-clock blood sampling on little girls, little girls, 5 to 7. It was like 8 to 10. It was like 10 to 12. Those are not the exact numbers. But what you can see is that by the time a woman is, having a regular menstrual cycle, it's like her estrogen will go, whoom, 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 whoom. That's normal. When a young girl is starting into puberty, it's whoom, whoom, occasional. If a girl is really young, like 5 to 8, normally her estrogen level goes big at bedtime. It's like, I don't know why it's at bedtime or what it accomplishes, but there's 1, maybe 2 spikes at night. And none of these spikes occur during the day. And so if you take something that's an estrogen or acts like an estrogen, stick it, feed a little girl fruit cocktail, or a fruit cocktail for breakfast and something else for dinner and a can of soda in the afternoon, she gets 3 spikes at a time that her body should not have it. And those are the spikes that are associated with breast growth. And one of the things that is clearly known is that little girls are growing breasts at a younger age than they used to. They're starting to have their periods at a younger age. Mm-hmm. And so it's a little so hard to ignore that. And so in a funny sense, when the guy from Forbes got all over my case, it was a gift because I hadn't thought about that. But when I did an internship in pediatrics, and I was one of the guys drawing blood tests around the clock in the middle of the night for the clinical research center. So I know what it takes to get those blood tests, and I've done it. But it's very interesting to realize how things like, it was like saying it doesn't make any difference. I'm saying, no, you don't get it. You don't understand how biology works. And so it's a very important point.
Yeah, I mean, and in terms of exposures, we're not always getting pulse because we have PBA is so, pervasive along with the phthalates and the parabens. And when you combine them all together, we have what's called the pseudo persistence. So, you have to be very cognizant of all of the exposures, not just from cans or just from makeup. We have other areas that some of these chemicals are kind of filling into our body through skin, through ingestion, through inhalation. And so, that's what makes some of these studies very difficult, in terms of just being able to, manage these confounders. But your study, this particular study, was just so remarkable because you're talking fine needle aspirations of actual tissue over 28 days, changing out those particular personal care products and seeing such a difference in the cellular tissue of the human body, which up to this point I hadn't heard much of other than what you mentioned in
There is no
England.
competing paper out there. This is an imperfect paper, but there is no competition.
Is there any competition pending? I mean, jumping off of this study, is there any, NIH, grants or anything in the works that you've heard of that are willing to take this on in a bigger way?
I have not heard about this.
Yeah.
I have no vote for NIH unless a whole bunch of people start bugging NIH. I had a conversation about 10 or 12 years ago with a senior member of ASCO, American Society of Clinical Oncology, past president of ASCO. That narrows it down to about 20 people. And told him, I said, I was really worried about environmental chemicals and why don't people do anything about it? It was kind of like he was polite and listened to me. And as we were going our separate ways, he said, yeah, Bill, you're probably right, but you're never going to prove it. And I think this is a step toward proving it. I get the magazines from ASCO and the new director of the National Cancer Institute talks about, at least she's quoted in the interview as talking about we're going to cure cancer and, prevent cancer, but preventing cancer is not looking at environmental chemicals as far as I can figure out. And I think, the big deal is nobody's going to make money. If I can prevent cancer with a mammogram, boy, I'm going to do it because I can sell a lot of mammograms. But nobody is going to make money by telling people to stop use things. Now, there are they should retool their cosmetics. And one of the things that, we did ask was we asked women whether they thought using these cosmetics for a month was okay. And they said, yeah, they had no problem. The fingernail polish chipped rather badly. So, but, if you're putting something horrible on your fingernail, I don't think it'll serve very much. It's really what you slather on your face, the sunscreen, the skin protecting stuff. And
feminine care products.
Oh, yeah.
Those are
let
fun.
You talk about that.
Yeah, well, listen, I'm sure you've had more than enough experience in your work and your career, but yeah, it's just another avenue of exposure. People don't think that tampons and douches and feminine, and pads and washes and all of these fragrances that we're taught are going to mask odor. And, the vaginal canal is remarkably able to clean itself. We don't need all of these things. And even has a microbiome all to its own. Which I think is remarkably, been with us for a long time, millions of years. So I think
millions of years, exactly.
Yeah, let's hope. But it's just been really an interesting, the washing of the marketing to young women and everyone in regards to what we think we need, which we don't always need in terms of products. It's just something to rethink.
Yeah, one of the things that I think is very important in this regard is that there is legislation in California that is going to require listing all chemicals. And I think it starts in 2024, all chemicals. And I was one of the people who went up to speak at the hearing on this. And there were two people who spoke in favor and two people who spoke against. And the people who spoke against it, industry, this is too expensive, these are our preservatives, blah, blah, blah. But the other argument was that by listing the ingredients, we will be listing what is in our trademark fragrance. And he said, if you know the ingredients, then people will go out and make it themselves. And I'm sitting there saying, okay, if you know the ingredients, people are still trying to figure out what's in Coca-Cola. It's like, people always, they'll make it a little bit and they'll have fun with it, but nobody's going to go make their own shampoo products. And nobody's going to make their own skin cream. It just isn't going to happen. And it's silly to argue that. And again, it's a specious, disingenuous argument. But it's going to be interesting to see what happens because people will be required. And one of the things about it is that a large number of the chemicals are actually involved in the fragrance. So, one of the things to do very early on, if you just want to change something tomorrow, buy fragrance-free things, fragrance-free shampoo, fragrance-free conditioners, everything fragrance-free. You don't need to smell better. I'm always amazed at a woman I worked with, one of the best nurses I ever knew. She'd grown up in the military and her dad would go places and the whole family would go along. She talked about learning to keep herself clean and okay with just plain water. And just plain water is much more effective than people give it credit for. And you don't need fancy things. I think back to the 1950s when Dial soap had the statue torso and the rotating in the mature male and the mature female. And it was the advertising. It was like, that's crazy. You don't need to be that way.
Yeah, I know. Again, it's a tough lift, but because there are so many of these great studies, like the one you were spearheaded, and so many others in terms of Hermosin, and even things through organic interventions. And I just think people need to hear the other side of the story, that you don't need to smell good and smell fresh necessarily, or you could smell fresh with safer ingredients. That's okay too. I mean, we have plenty of products. It's a very competitive market now, and hopefully it'll get even more competitive. I have a quick question. Putting back on your breast surgeon hat, as a woman who has breasts, I wanted to find out, having been told that I have dense breasts, and I know a lot of women are being told that, I have yet to find a woman who doesn't have breasts that are dense in 2023. And I have yet to reach out to radiology colleagues and look up the papers. But is this denseness not so much an anomaly anymore and more of a common finding or routine? And is that, in your opinion, or, related to the endocrine disruption chemicals and all of these exposures, xenoestrogens as they're called?
Well, the first thing I would point out to you is that dense breasts is not something that a woman acquires. Mm-hmm. Dense breast is something that she hangs on to. Okay. And the reason I say that is we don't do mammograms very much on teenagers, but if you do mammograms on teenagers or women in their 20s, they're dense. They're almost always dense. I've yet to see a fatty breast in a woman in her 20s. I've seen many mammograms in women in their 20s, but I've yet to see one that was really low density. So, and the second thing you got to realize is that the data sets are based on women who have mammograms who are almost all over 40 and very heavily on women over 50 and 60. So a lot of what's going on with breast density is that it's the persistence of what goes on in a younger person. Now, dense breasts are associated with cancer. And you asked about personal experience, and that is that as we collected FNAs over the years, because as I explained to you, we were using human cells, but we were using fresh human cells. So we would get a sample on Susie Joe, and we would be able to work with that for about 3 months before it died. But you can actually do things before cells undergo transformation. And we argue that that's much closer to normal. So over the course of the time that we did this, we had samples from 240 women. And these were all women with breast cancer or some sort of high-risk lesion. And what struck me is we were also tracking breast density. And about 3/4 of them had dense breasts. So I do believe that there is an association between the breast density and getting breast cancer. And I think persistence post-menopause may very well be influenced by that. I'm not saying it's not that case in women in their 40s. I just don't know. And I don't think anybody else does. Typically, a woman who's had a couple kids, as her breast tissue settles down after pregnancy and nursing, it will lose some of that denser structure and become less dense. The question is, why do some women not lose that structure?
Right.
And that is a question. And it might be related to the hormonal effects of the things that we all swim in all the time. I mean, we're around hormonal things all the time. All of us.
Right. And when I read some research by Dr. Soto, I can't remember her first name, but there was an incredible study where she had done where environmentally relevant levels of BPA changing the breast tissue to be more dense. And I thought that was a very interesting phenomenon.
Anna Soto.
Anna Soto, yeah.
I've seen that. I will accept that. I don't want to.
I'm not trying to corner you. I just wanted to get your thought. And then also, what would you say to a woman who does have dense breasts? They on mammogram. Would you say that they should generally have, I'm not going by guidelines necessarily, because we know that guidelines they often lag behind the science, the guidelines, as most of us know with colonoscopy. And now mammograms are, they were 45 when you got screening. Now they're down to 40 with a lot of, problems in those 10, 20 years in between. I guess the question is, would you recommend ultrasound to help with managing breast mammogram? What do you think that adds value?
First of all, the decision to recommend screening mammography start at age 50 and then age 45 and then 40 is a purely economic decision. There was always data that there was a benefit in doing mammography in women between 40 and 50. Laszlo Tabar showed that a long time ago. It was deemed to be too expensive. So you can figure out where your healthcare dollar goes. It's all those CEOs that are getting $200 to $500 million a year. In terms of ultrasound is a funny thing. If you see something on an MRI or a mammogram and you're going to biopsy it, if you know exactly where to go, it's like in this part of the breast, the ultrasound is generally pretty good at finding it. Like on an MRI, I think it's about 75% of the time they can find the lesion. If you can find it with ultrasound, it's a whole lot easier biopsy than trying to find it with a mammogram or trying to find it with an MRI. So ultrasound is really useful if you know where you're looking. Okay. The use of screening ultrasound is not agreed. I will say this. UCSF, University of California, San Francisco, California Pacific Medical Center in San Francisco, and Stanford University Medical Center, Palo Alto, do not do screening ultrasounds. This is an East Coast, West Coast thing. People on the East Coast are more
Biggie and
enamored of
Tupac.
it.
Yeah.
Pardon?
Go ahead. I said Biggie and Tupac if you like rap music.
Yeah.
Anyway, go ahead.
It's an East Coast, it's the left coast and the right coast.
Sure.
But, and we're on the right side, obviously. But no, anyway.
You're on the right side of the country if you're facing. No, okay, go ahead.
Okay. I guess it depends whether you're looking from Canada or whether you're looking from Mexico. Anyway, I have had patients who had cancers found by ultrasound that were missed by mammography. Mammography is not perfect. People point to those. The difficulty with screening ultrasound is there tend to be more false positives. So you end up with more things. Oh my God, what's that? Which is why the folks out here tend to restrict ultrasound to using it to work up something else rather than simply to go looking. No, there have been a variety of systems. The most creative one that I remember years ago, they wanted to make ultrasound better. So they had a woman lie over a small bucket of water, kind of like a dishpan, and put her breasts in the water, and then the transducer didn't touch the skin. Most ultrasounds, the transducer touches the skin. Right. You can do the same thing through water. That's how the Navy finds submarines and things like that, and do the scanning of the whole breast in water. And after a whole lot of running around and doing a lot of that for a couple of years, they concluded it really didn't add anything to doing mammograms. Mammograms are great. They are imperfect. They miss things. MRIs are great. They are imperfect and they miss things. There are variations on mammograms coming along. I don't think anybody's actually doing it as a regular test where they do a contrast enhanced mammogram now. And that will probably be a lot cheaper and easier than an MRI. And certainly you won't have to go in the machine that goes bang, bang, bang over your head.
But you will need gadolinium, correct?
No. That's the contrast.
MRI.
The MRI needs gadolinium.
Right.
But the contrast enhanced mammogram, it uses radioiodine. Excuse me.
Okay.
It's not radioactive. It uses an iodine based contrast dye. So, if somebody has kidney disease or has an allergy to iodine dyes or an allergy to shellfish, you would never use a contrast enhanced mammogram. But if somebody doesn't have those things, then the contrast enhanced mammogram looks like it may be a way to improve routine mammography without having to go to MRIs. And as you say, the MRI it always requires gadolinium. An MRI without the contrast is kind of like, so what?
Right. And my issue with gadolinium, because having been through this whole process myself, is that gadolinium has its risks too. And they just reformulated gadolinium a couple of years ago so that it's safer and it clears the system better. But again, it's like we are an imperfect system of trying to, would we trading off Alzheimer's and dementia to save our breasts? I actually had this conversation with the breast radiologist. So, you want to make sure you're doing this in a judicious way, but a lot of insurance doesn't cover it. I mean, I had to fight for an MRI and I had to prove that my Gale score from 5 years ago, and is Gale score such a great score? I mean, these are kind of the complex issues, right?
Yeah, well, the Gale score doesn't include breast density. There's the breast cancer research, Breast Cancer Screening Consortium, BCSC, that centers out of San Francisco and has patients from a couple places here, Seattle, Chicago, New Hampshire, and I think one other place. And they do a screening score based on that includes breast density. And on the other hand, they don't include some of the factors like early menarche or late menopause that are in the Gale score. And they only have a yes-no on family history. Gale score is only a yes-no. On the other hand, they include whether or not you've ever had a biopsy and whether or not the biopsy had atypia or not. So hopefully these things will kind of work together. And I know the people are doing the one out here. If I'm counseling somebody, I I have a little pocket thing. I can do the Gale model and I also do the BCSC calculator. And I say, okay, this is one way. And they also do different things. Both of them predict for 5 years. The Gale model predicts 5 years in lifetime. The BCSC is 5 years and 10 years. And predictive models are useful to help people kind of get perspective, but they're not perfect.
Especially in the case that our environment is changing so rapidly.
Oh, well, this is when you start seeing cancer in younger women. We've peed in our own swimming pool, and we're dealing with that.
Yeah. Yeah, no, this is a really important topic. And I think, so many women are left confused. And I think a lot of practitioners don't know what to tell their patients. I will give them that. I'm a strong fan of, getting whatever screening you can get that's certainly within the guidelines. But sometimes you have to be more aggressive, and you have to really work with doctors that are willing to help get more data or get more diagnostic testing. And that's not always easy to find. So that being said, I have another question for you.
Sure.
And then I know we are running out of time because I'm enjoying talking to you so much. You're such a wonderful person to share such great information. Women who have had breast cancer, women who are looking to have breast implants, whether it's for aesthetics, whether it's for, for any number of reasons, that women get either after breast cancer or even if they wanted just enlargement. I want to know your thoughts. Given that you're so specific to your work with chemicals in the environment. I used to say it's sort of, almost feels nebulous whether it's a saline breast implant versus a silicone. And we know that silicone is everyone's a little fearful of breakages. But I thought, well, what about the plastic they're encased in? Isn't that something that would be immunologically a problem? So I'm just kind of wanted to hear your thoughts if you're willing to share.
Breast size and whether or not a woman wants her breasts changed is a very, very personal decision. Let's take that, and then we'll talk about reconstruction. I think it's very important for people to understand what they're doing. The issues with breast implants. For a while, people had textured implants. It was supposed to be an irregular surface that would not contract because the body treats everything that's not there as a foreign body, and it makes a scar around it. And you put in something that's shaped like this, the body will tend to try to pull it smaller, because if you do the math, the distance around a circle is always less than the distance around an ellipse with the same area in the middle. So they always contract a little bit. So if you're putting in an implant, you got to figure out what you're going to do to keep it from contracting. Most of the contraction comes early on. So the textured implants, for reasons that I don't think anybody understands, but they are associated with a lymphoma. And so if a woman has textured implants, she probably should think about either very careful monitoring or maybe those I would change out.
Or ask their doctor if they don't know, because I have a lot of patients who just don't know.
No. The plastic surgeon should have a record, and the other person should have a record is the hospital. But the law is most places they have to keep the records for about 7 years.
7 years.
Well, California, it's 3, but your malpractice insurance tells you 7. And they really say 10 is better. So you've got to be careful of that. So the first thing is that you got to realize that you got to think about why you're doing it, and try to be objective about whether or not you really want to change the size of your breast, because once you do it, you've really changed the size of your breast. Now, I've had patients who had their implants, didn't like it, and had them taken out, and it actually doesn't work and isn't all that bad. I mean, plastic surgeon goes, oh, it's awful, it's going to be big and floppy. It doesn't necessarily end up being that way. If somebody's got a small breast who's trying to make it bigger, now if you got a big breast and trying to make it bigger, it may be hard to take the implant out. You always take it out, but I mean, it may have some consequences in terms of appearance. But a small breast made bigger, if you take the implant out, it kind of just goes back to being a small breast. The risks of that, it's very hard to know, because I don't think that anybody has a clear idea. For a while, the FDA banned silicone implants based on the silicone gel on the inside, but they allowed saline-filled implants. Now, saline implants they're just not as good. I mean, people have tried filling. I think the worst thing is somebody filled them with vegetable oil for a while, and that was horrible because apparently, no matter what you think is sterile, it's not. And but I can talk about it. I can't give you a clear answer because I don't think there is a database to give a clear answer. What I do know is that when the FDA had a lot of their concerns, there were people who were, I think, being double counted in different places. On the other hand, I don't particularly like the idea of putting things in someone's body that they don't need. Now, that's for somebody doing it strictly for cosmetic purposes. If somebody has major asymmetry in their breast, then I think that's a fair thing to consider. Our society is rather unforgiving, unfortunately, of women who do not have breasts. You don't have to be big, but you have to have some sort of a bump there. And society.
That's an East Coast, West Coast thing too, right?
It's a funny.
It's a joke I have with friends that I'm glad I don't live necessarily on the West Coast because it tends to be something that's a little bit more, I don't know what the right word is without getting in trouble. But anyway, the idea that there can be cultural changes around the world, even in certain countries, there's a different value.
Cultural change.
In terms of size. In terms of size,
exactly.
Yeah.
Now, the issue of if somebody's, we don't do that many mastectomies, but a person for cancer, but a person can choose that. Person can always choose to have a mastectomy. And if she feels more comfortable having a mastectomy, for heaven's sake, stop arguing about it. But on the other hand, I don't think anybody should push somebody to have a mastectomy for small, reasonably resectable tumors. The exception to that is if somebody is young, has a breast cancer mutation, and, they may get through this one, but if they have a mutation, they're just going to get more. And it might make sense to just take the breast tissue out and get rid of it. In that setting, if implants are what's appropriate, I think that the risks are small enough to be acceptable. I don't think that anybody can tell you there's no risk. If somebody tells you there's no risk, they're not being totally straightforward with you. But I think that the risks are not terribly high. Okay.
Interesting. And in terms of reconstruction, when people have options, do you tend to kind of gear people towards, adipose tissue movement and putting fat into breast tissue? Or do you tend to just sort of stay out of that opinion and just kind of give people what they are?
What I would say to persons is that if they have a sufficient amount of tissue, that moving their own tissue is by far and away the best option for appearance, mobility. Remember I talked a little while ago about how the breast shifts? Mm-hmm. If a woman has an implant reconstruction, the capsule or the scar that forms around that will be in one place. And unlike her usual breast, which kind of goes up and down, that capsule will frequently, not always, will frequently be attached to the chest wall. Then it doesn't move up and down. So the plastic surgeon puts it in one place and knows that it's going to be in one place. If you are lying on your back and you're looking at your normal native breast, they will lie a little bit to the side. If you put the implants in that position, when a woman stands up, they're going to look really strange. So the plastic surgeon always puts the implants to where they'll look good when a woman's standing. And they, in fact, when they're doing the surgery, patients lying there, they do everything, and then they tip the table up so they can see what it's going to look like. They position it so that it will be in a good workable position. Because what you're really doing is you are putting it in a place where the world won't stare at you when you walk down the street. I mean, it's a funny thing in our society that people, what's wrong? And I have one patient, and she had a mastectomy by choice. and no reconstruction by choice, and did not choose to wear an implant. And she was a very successful person in the San Francisco scene. And when you saw her, it was like one and none. And that just was her statement. And I always thought it was a very strong statement. You had to know her. She was a force.
Well, you're normalizing something that's considered, at some level, there's a feeling of shame or difference because you're not looking like others. And I think that when people break that mold, I think it's pretty cool, actually.
I think it takes a lot of guts.
Yeah, totally. And immunologically, in terms of, I don't want you to go out of your lane, but, as a rheumatologist, I see a lot of things that happen from, any foreign bodies in the body. I'm not going to just pinpoint breast implants, but IUDs and, there's a variety of things. I'm not saying they're all bad and they shouldn't be made that choice, but it just, after years of experience, you start to get a gestalt of what you recommend beyond what guidelines say. And I think it's just nice to hear when doctors want to share.
Well, I should have remembered that you're a rheumatologist and tossed it back to you in the first place. But that's the argument as to whether or not they're rheumatic, type of issues that come up with silicone, particularly the leaking silicone. And then you get in the argument of that, well, should you change them out prophylactically? So that's a hard question.
Or even the plastic casing of saline or silicone. I mean, I guess that's my question also, and I don't have an answer for this.
I don't have an answer either.
Observational opinion, but nothing that could be hard and fast. But anyway, I think it's just a really interesting area to explore. And, so many facets of choice that women have or anyone has in terms of these kind of medical procedures. So it's just something to think about in the context of what we're talking about. Right. I think it's particularly more interesting. So I'm going to let you go soon because I know you have a life beyond this podcast. But I want, you've written novels, you are an outdoorsy guy, you do a lot of things with family. Are you still practicing? Can people find you and consult with you and get your great advice if they'd like to as a breast surgeon and beyond?
Yeah, I don't see patients in the office. Actually, I saw one patient in the office in the last 18 months. I do have access to an office. I do a fair number of Zoom calls. I have a website, www.drwilliamgoodson.com. There's a contact email. There's stuff there that talks about my practice. And you certainly, I'm happy to talk to people. There's a funny legality as if I talk to somebody outside of California where I'm not licensed. In theory, I can give them advice and I can discuss things and help them understand things, but it's not quite the same thing as telling them what to do. So you probably figured out I love chatting about whatever's going on. And I pride myself on knowing a lot of the little backstories because that's what makes people remember things. But if somebody wants to contact me and if they do, my former office manager still checks the email a couple times a week and she'll be in touch and happy to do that.
Good. I'll put I'm going to put a bunch of stuff on our podcast page for this interview, but one of them will be your website, so people can get in touch with you. Yeah. What are your parting words? Are you hopeful for the future of women's breasts, women's health, of environmental health? I mean, are there some things that you are just, optimistic about, given that you teach young people and I'm sure you have contact with medical students and, tell me what your thoughts are as you part company.
I think we have to live with chemicals. I noticed that, the title of the book you wrote was Guide to Living in a Chemical World. There was a book written in the late 1930s called Man in a Chemical World, man in a generic sense, and talked about the wonders of what all the chemicals are going to do. And here you are 50 years later writing about the dangers of all the chemicals. What comes to mind is the Disney story and movie in the 1950s called Our Friend the Atom. And radiation was going to be wonderful.
Right.
And nobody really had quite understood how double-edged that sword is. And so, we've kind of learned, we had to learn about nuclear bombs, but we also had to learn about radiation sources. When I was a kid, you would go to the store and get your shoes, and then do they fit right? So they'd take an X-ray up through your feet to see whether or not your toes fit the shoe right. And I keep waiting for my toes to fall off. So there's a higher danger with radiation. We've been forced to confront that more quickly. I think we're only beginning to confront the degree to which we've, contaminated our own swimming pool. And I come back to the analogy of swimming pool because it's in the water. We, for whatever your religious background is, we live outside of water because we have a successful barrier between my insides, which is wet, and the outside air, which is mostly dry. If you lose that barrier, then you're dead. And it's the internal swimming pool that I'm talking about. What goes here goes inside. It's like the stewardess said on the airplane landing in Las Vegas, remember what happens in Las Vegas goes on YouTube. But it was. I think people need to be aware of this, and in the casual conversations with your friends, you need to point out that chemicals really do have risks. I have a son who's moved to the Midwest, and the gardener is absolutely, the guy that mows our lawn cannot understand why he doesn't want to put Roundup on the weeds. And I told him to put Roundup on the weeds. I wasn't going to come visit. And I was going to take away my grandchildren because I'm not going to blame the grand do it. But it is a big thing. Agribusiness in the United States has been courted by Monsanto, now Bayer, all these big chemicals companies. And the farmers have been sold a bill of goods in a way. And we also have, single crops that, the same as crop year after year after year. Yeah, you're going to grow something in the soil. You got to rotate the crops. But it's a very, I think the one thing that I would say, if you leave a parting side, and this is, you probably alluded to the fact that I've written a book sort of exploring this idea. Men need to understand that they are at risk too. This is an issue for breast cancer. I do believe that. It's probably an issue for prostate cancer. And it's an issue for male fertility. Sperm counts are dropping, and they have dropped for a long time. And I remember somebody, talking about, as men wear briefs so that their scrotum is warmer and they don't make sperm, but I don't think that's the answer. And, you can look at things where they're Army recruits that have been tested over the years, and they're just as a lower sperm count. And I think the important thing is that the decisions in this, in terms of what goes into products, with few exceptions, are made by men. And I think somehow or another, men are a bit of an embarrassment because men tend to think this is not a problem that's going to get them. It's the macho thing. Men need to understand that their sons, their progeny are really, really at risk. So men need to get involved in the conversation.
Yeah. Yeah. No, it's a great piece of information to share. It really is. Yeah. And, women have breasts, but men have breasts, and men get breast cancer too. So we have to think about this as an every human problem. Every human problem.
Exactly.
Absolutely. So, so on that note, I am going to part ways, but I got to tell you, this has been such a great conversation. I'm so thrilled that you took the time to join us and share all your information with this audience. And again, for the audience, I will put as many links as I can to make sure that you get everything from this conversation that we discussed. So thank you so much, and be
Been
well.
my pleasure.
Appreciate you. Yeah.
Take care now. Bye-bye.